Good morning. We're going to start on time because we have some incredible presentations today as part of this session. Apologies for my voice. My name is Greg Sawicki. I'm a pediatric pulmonologist and the center director at Boston Children's Hospital. And along with my co-moderator, Chandra Gordon, we're super excited to share this workshop around health equity and social complexity in CF. We're going to let the work speak for itself. It has a lot of powerful messages, a lot of very important points, and a lot of things brought out from both research and clinical care. We're really excited to be bringing programming to NACFC around health equity. We realize it's a very important topic, and for all of us in the room, it's important for all of us to remain advocates for equity topics throughout our care teams, with our researchers, with our collaborators, and for people not in this room. I encourage you to go to the other health equity access and care delivery sessions throughout the conference. They're all notated through a specific track, and there'll be multiple sessions throughout this conference where these topics will be discussed. For this workshop, each of our speakers will have 15 minutes, followed by 5 minutes of Q&A. You can put in questions through the app during the presentation, but you can also come up to the mic after each presentation. So without further ado, we'll get started with our talks.
All right. Our first speaker for this morning is Rachel Holland. She is a third-year medical student at Daisy Howells University, which is in Nova Scotia. And in addition to her talk today, she is also involved in several studies regarding race-based respiratory health.
So it's a pleasure to be here with all of you today and a privilege to have the opportunity to share our research. And I have no relationships to disclose in relation to this presentation. So Canada has historically boasted one of the highest cystic fibrosis survival rates in the world, with a current median survival of 57 years of age. However, studies from the United States have consistently found disparities in outcomes for non-white individuals with CF compared to those of white European ancestry. And this is true even after adjusting for several confounding factors. Most notably, non-white individuals have been found to have worse survival. And it's been unclear if similar inequities exist in our Canadian CF population. In this study, we therefore aim to determine if there are inequities in outcomes by race or ethnicity in the Canadian CF population. So in this population-based cohort study, we used the Canadian CF Registry, or the CCFR, and analyzed data collected between 2000 and 2019. We analyzed the data using basic descriptive statistical summaries and used a Cox proportional hazard model for the survival analysis. And then I also just wanted to take a quick moment to mention that in carrying out this research, we also partnered with Elevate Canada, and they're a virtual volunteer initiative that enables Canadians living with cystic fibrosis and their families to share their unique experiences, perspectives, and priorities to help guide cystic fibrosis research and care programs. So we had 3 consultation sessions with non-white Canadians living with CF to help gain insight to help meaningfully guide our research. For the purposes of our analysis, we divided all of the patients in the CCFR into 2 groups: white, which was those listed as Caucasian in the registry, and non-white, which included patients listed as Black, Asian, South Asian, Hispanic, First Nations people, those with 2 or more races, and other. And it's important to note that race in the CCFR is assigned by clinic staff, with the vast majority being labeled as white. And then we also combined all of the non-white individuals into one group due to the numbers in each individual group being too small to carry out an analysis. And then those labeled with unknown race were excluded from our analysis. So to quickly orient us for the remainder of the presentation, the white group is always going to be represented by the purple, and then the non-white group is always represented by the orange. So firstly, we analyzed the age distribution of each group and found that the non-white group was younger, with a higher proportion of individuals aged 0 to 19 compared to the white group. We realized that the non-white group being younger had the potential to skew the results of our analysis, and so we performed an age-specific analysis to mitigate this for several of the outcomes to follow. So the primary outcome that we wanted to analyze was survival. So in this Kaplan-Meier graph, we can see the survival probability by age, and we can see that the non-white group, represented by the orange, is dying younger. The median age of survival for the white group in our study population was 48.8 years, and this is compared to a survival rate of 39.5 years in the non-white group. So this is a 9-year survival difference between white and non-white individuals with CF, translating to a 1.85 times higher risk of death for non-white people with CF in our 20-year study period. We do realize that in our small non-white group, there were not a lot of deaths in the study window, but there's still clearly a survival gap. And it's important to note that the survival analysis we conducted is not comparable to the statistics reported in the CCFR, just due to the differing study windows of the report. We also assessed several characteristics present at diagnosis in our study population, and the most important takeaway from this is that at diagnosis, both groups appear to have very similar disease severity, and yet we still saw these drastic differences in survival. So the percentage of females, the percentage of those with pancreatic insufficiency, and the percentage of those with meconium ileus at birth was very similar. We also compared the age at diagnosis between groups at both the beginning and the end of our study period, and the age at diagnosis remained quite similar throughout the 20-year period and was very similar between groups as well. Since the introduction of newborn screening programs in Canada in 2007, a greater proportion of newborn diagnosed individuals have been non-white. And we do realize that this is a different pattern than what's been observed in the US, where a lower proportion of non-white individuals are being diagnosed by newborn screening. CF Canada has been working on a more in-depth analysis of the newborn screening program in Canada, and further details on this are being presented in poster number 387 at the conference this weekend. Genotype mutations in CF are most commonly divided into homozygous delta F508, heterozygous delta F508, other, and then missing. So just a quick note that just the fact that we're classifying mutations as based on presence or absence of delta F508 is a very Eurocentric system that is certainly potentially playing into the results that we're finding with disparities. So not surprisingly, we did find that a much higher proportion of the white group had at least one delta F508 mutation, and therefore making them eligible for a CFTR modulator. And of note, in Canada, you currently must have at least one delta F508 mutation to be eligible for modulator therapies. And then in the non-white group in comparison, there was a higher proportion of genotypes listed as other, and then as well as a higher proportion of missing genotypes. So this made the non-white group overall much less likely to be eligible for a CFTR modulator. Another one of the important outcomes we wanted to assess was lung function. So the graph up on the screen here now is showing the FEV1 and the standard deviation using race-specific equations. And this is currently the standard practice of interpreting lung function measures. So this method leads to a very similar FEV1 between our groups. And then past the age of 30, we are seeing that the non-white group has a higher FEV1, likely representing a survivorship bias. However, it's been demonstrated in non-white CF populations that race-specific equations are essentially considering observed differences in FEV1 between populations as innate and normalized disparities between groups. So when we applied race-neutral equations to our study population, as seen on the right-hand graph here, the non-white group actually has lower FEV1, appearing sicker than the white group. So the use of race-specific equations is therefore making the non-white population with CF look healthier than they are, which may delay treatments such as the initiation of important therapies and referral for lung transplant. And we can see that effect at play here, where we did find that the white group was nearly twice as likely to receive a lung transplant. And then we also looked at how the infection rates of common pathogens compared between groups and found that the only pathogen that differed greatly was the rates of Pseudomonas. So Pseudomonas infections were more prevalent at a younger age in the non-white group compared to the white group. We also assessed healthcare utilization in terms of hospitalizations. And we can see that the non-white group in orange is consistently having higher rates of hospitalizations amongst our full study period from 2000 to 2019. And this overall translated to about 1.5 times the rate of hospitalizations in the non-white group. And then the final aspect of care we wanted to look at was the prescribing practices for various common CF medications. So here, looking at Dornase alpha and hypertonic saline prescriptions, we can see that for hypertonic saline especially, white children are being started on therapies at a younger age than non-white children. So overall, our study uncovered several important differences in the outcomes and care of non-white Canadians with CF compared to white Canadians with CF. So the non-white group had worse survival and also a younger age distribution, and this is despite both groups looking nearly identical at the time of diagnosis. They also have seemingly equivalent lung function when we look at race-specific equations, but yet they're having earlier infection rates and higher hospitalization rates. And despite this, the non-white group is still being initiated on certain treatments at a later age. And our study does have several important limitations that I want to highlight. So the non-white group was very small, which is hard to avoid given the small percentage of non-white individuals with CF in Canada. But it's also very heterogeneous since it included all non-white patients in one group. And we realize that this isn't ideal and that when we're lumping a very ancestrally and geographically diverse group of people into one group, there's certainly the potential to underestimate the disparities in any one particular group. And then secondly, within the CCFR, race is determined by clinician observation, and this has the potential for miscategorization and bias. And then thirdly, the CCFR does not currently include a measure of socioeconomic status. We did talk briefly about prescribing practices in CF, and prescription medication coverage in Canada tends to be correlated with SES. However, some CF medications are also covered by government formularies, so it would be helpful to have a measure of SES in the CCFR, and that would help us to disentangle the effects of SES versus some of the systemic biases in treatment. So in conclusion, our study found that there are systemic biases in outcomes and care for people with CF in Canada who are not white. And this is true despite the white and non-white groups looking very similar at diagnosis. Most importantly, though, our intent with this research is to highlight that there's opportunity to modify practice to improve equity and outcomes. So these steps could include analyzing lung function using race-neutral equations, promoting more equitable prescribing practices, and then allowing patients and their families to self-identify their race to improve the accuracy of the data that we collect in the CCFR. So it's been a pleasure having the opportunity to share our work with you, and I'd like to welcome any questions at this time.
Thank you, and please come up to the mic with questions.
Hi, my name is Megan McGarry. I'm from University of California, San Francisco. So thank you so much for this important work. I think it's like, we really need to be looking at this. And it's devastating that it's awful and on so many different levels. So I just want to ask two questions for you. So in your conclusions, you talked a little about next steps, but what about referral to transplants? Is there something different about the process? Why are patients not getting referred for transplant or getting transplants?
Yeah, that's something that we did discuss after finding this data. And then we do think that some of it could be due to the way that we're interpreting their lung function. So if their FEV1 is high and it's looking better than it is, they're not appearing as sick, so they're not meeting that criteria in their FEV1 to be referred for transplants. There also potentially could be lots of other factors at play, including access and things like that. But that's something that we were curious about as well and had lots of discussions about.
Yeah, I think it would be really important to also look at bias on what the criteria are for who qualifies, besides objective numbers too, on who will be a good fit. And then the other thing was, so about the delay in medications, did you look and see at all about whether it's affected by delay in diagnosis? Are they getting treatments later because they're not getting diagnosed later? Or is it because Are they getting diagnosed around the same time? And there really is like a treatment bias.
Yeah, we didn't directly look at that, but given that in Canada, we're actually seeing that newborn screening is picking up more non-white individuals and they have a younger distribution. So likely it wouldn't have to do with the time at diagnosis being later, since we are finding a pattern that they're actually being diagnosed younger and then yet still not being initiated on treatments as early.
Thank you. Thanks for this work.
Thanks.
Great presentation.
Thank you.
Hi, I'm Mel Collins. I'm from Hartford, Connecticut. My questions, I have two. The first one is, do you look at educational level in Canada as part of your CF registry? I just feel like when families don't understand the therapies we're asking them to do, it's hard to make your child do it every day.
Yeah, from my understanding, there is no measure in the CCFR in terms of education level of the parents or the individual themselves. And I know that often can also be used as a proxy for socioeconomic status. So that's not data that's currently collected, but that is a very good point, and it could play into some of the disparities that we're seeing.
And the second question is, did you notice a difference between centers such that maybe one center has more implicit bias than another center and patients did better at different places?
Yeah, that's not something that we did look at. We considered there's 40, I believe, CF centers in Canada currently, and we looked at everything together. We do realize that one or two larger centers could be contributing to a lot of these outcomes, since there's no standardized methods for CF care. It's kind of centered specific. So that is something that we considered, and we've considered looking at, we have one CF care center in Nova Scotia, and we've considered kind of looking more specifically at a center by center basis.
Thank you. Tremendous presentations.
Good morning. That was a lovely presentation. My name is Louise Giles. I'm currently at the Children's Hospital San Antonio, but I used to work in Winnipeg, Manitoba, so I'm a fellow Canadian. The problem, I'm just sitting there thinking about the fact that we had a lot of First Nations patients who had cystic fibrosis, and part of that is that newborn screen didn't hit Manitoba into the 2000s. I was there, it was about 2004 or 5. It wasn't consistent across the country, but the problem with a place like Manitoba and basically the whole of Canada is geographic distance. We had a lot of patients that were in northern Manitoba. They were fly in, fly out communities, often with bad weather, like there's already snow there, no consistent roads into some of these communities. How can we look and try to tease some of that out from the data? Because part of it might just be the geographic realities of living in Canada.
Yeah, that's certainly true. And we've thought about, even in regards to our Nova Scotia population, we have one center and lots of rural communities. We actually are working on the beginning of a grant that we've gotten from CF Canada. And as part of that, we are going to look at the geographic, kind of the distance from the CF Care Center that patients are attending, because we can see patients' postal codes. So we'll be able to map out kind of the distance from center. And then we also are interested to see how patients' distance from their center and their access to care is playing into things.
Just for the fellow Texans in the group, I know Texas is a big state, but in Manitoba, some of our patients had to drive 10 hours to come to CF clinic or to the Children's Hospital, period. And that was only halfway up the entire province. So it's huge, the geographic barriers to care.
Hello, my name is Davina. I'm located now in Nebraska, but I'm a Canadian citizen, grew up in Saskatoon, Saskatchewan. So actually, my question is a lot about geographical as well, just because of how vast it is. I did notice that it was just around 300 non-white that you identified in the study. So I'm kind of curious about if you counted, like when you looked at all of your study, were there any provinces that were kind of excluded out of it that weren't having a huge non-white population compared to another? So I guess I'm curious about, as Canada as a whole, where we're looking, like, Saskatchewan, for example, where there are like 5 patients from Saskatchewan. It might not be that specific, but I'm kind of curious about the more broad look at it, especially with such a small number.
Yeah, we didn't look at anything center specific or province specific. So we used all of the eligible patients in the CCFR and didn't take into consideration the center that they're being treated at or specific provinces. But again, I do think that where every CF care center kind of has their own methods of practice, it would be interesting to look at how each individual center, how their data kind of looks compared to others to see if there's a few centers that are driving these results or if it's pretty consistent across the board.
Perfect. Thank you very much.
Good morning, and thank you for the presentation. My name is Ana Torres Thornton. I'm working out of Joe DiMaggio in Florida via Texas Children's. So, my question is more from the social work aspect, like the non-white population. Were there any like language differences, cultural differences that might have influenced some of the studies? I mean, was that picked up at all?
Yeah, that's not something that we were able to pick up. We did have discussions with our team kind of in regards to that with cultural differences, as well as we have a lot of immigration into Canada right now. And there is a mark in the CCFR that tells us if patients were born in Canada or if they were born in another country. So we also thought that it might be interesting to add that variable into our research and see how that potentially is affecting results to see if it's more so burdening patients who weren't born in Canada or have different cultural backgrounds.
Yeah, because we're seeing a disparity in like access to the medications depending on the country that they're coming from. Our center picks up a lot of people internationally, so that's thank you so much.
Thank you.
Okay, we do have a question online, and it was: is there less need for hospitalization for non-white patients, or are there other? Sorry, it just switched on me. Okay, is there less need for hospitalization for non-white patients, or is there other reasons why they had lower hospitalizations?
I think in terms of hospitalizations, it's really a proxy for pulmonary exacerbations and the overall health. So our assumption when we found that, and then going along with our other results that we found, was that non-white patients are having more pulmonary exacerbations and therefore have a higher overall disease burden. And that's why they're requiring more hospitalizations, because we did also look at the clinic visits, and the standard clinic visits was very similar between groups. So it's just kind of in terms of those acute care needs that we found the difference.
And I have one more question about modulator eligibility, which you did mention that the non-white population, which is similar to data internationally, is less likely to be eligible for modulators based on genetics. This data that you're showing, however, predates modulator availability in Canada, correct? And so what do you think this means for, if you were to repeat this analysis in 5 years, once modulators become more accessible to certain populations in Canada?
Yeah, I think that if we were to repeat this study in a few years, we would actually find even wider disparities. Since currently, like I said, in Canada, you have to have at least one Delta F508 mutation to be considered for a modulator. So I think that would widen the disparities even more. And I think that there should be a push to classify more of the non-white patients' genotypes into a specific functional class, so we can start to see if there are other mutations that could work with the CFTR modulators to help mitigate that.
Thank you. Thank you for an incredible talk.
Thank you.
All right. Our next presenter is Georgine Hergenroder from the Children's Hospital of Philadelphia.
All right, good morning, everybody. And thank you so much to Ms. Gordon and Dr. Sawicki for the opportunity to share with you all today. I'm going to be talking about the characteristics of people who are eligible for ETI who are in fact prescribed ETI. And I don't have any disclosures relevant to this presentation. Registry data indicates that not everyone who is eligible for ETI is in fact prescribed ETI, but there's limited data out there on what the characteristics are of people who are on ETI. And that was really the objective of our study. We wanted to analyze the demographic and clinical features of ETI-eligible people who were prescribed ETI. What we hypothesized was that people with CF with higher lung function and fewer pulmonary exacerbations in the preceding year, essentially people with overall better lung function, would be less likely to be prescribed ETI. We performed a registry analysis in which we used the CF Foundation's patient registry, and we include any participant who was age 12 and above with at least one copy of F508del, who was enrolled in the patient registry between 2019 and 2022. We excluded participants who had a history of a lung transplant, those without at least one copy of F508del, those who were missing at least one annual interview or clinic visit for each of these 4 years, and those who were on ETI as a part of one of the pre-FDA approval clinical trials. In addition to descriptive statistics with chi-squared analysis, we also evaluated the time to ETI prescription with cumulative incidence curves and Cox proportional hazard ratio models. So this first table that I show you encompasses the overall demographics of our participants. And you can see that overall, between the two groups, there are a little over 15,500 people included in the study. In the left column, I have my arrow is on the wrong screen. In the left column, I show you the people who were not prescribed ETI, and in the right column, those who were prescribed ETI. And what you can see is that overall, among eligible people, 92.4% were prescribed ETI. When we look at age, compared to the referent group of people aged 18 to less than 30, we found that both younger people and older people had lower rates of ETI prescription. We didn't find any difference by sex. And then when we looked at race, we found that as compared to white people with CF, Black people with CF had lower prescription rates. And so really looking at those numbers more specifically, whereas 7.5% of white people with CF were not prescribed ETI, we saw 10.9% of Black people with CF were not prescribed ETI. When we look at ethnicity, we also see that there were lower rates of ETI prescription among Hispanic people with CF as compared to non-Hispanic. And lastly, we looked at insurance as comparing the referent group of private insurance with those on Medicare, Medicaid, or other insurance, which would include things like TRICARE or other military health plans, Indian Health Services, or state special needs programs. We found lower rates of ETI prescription among people who were in the either no insurance or other insurance category. Then we looked at more specific markers of either lung health or overall health. And we found when looking at lung function that people with lower FEV1, so less than 90% of predicted for their FEV1, had higher prescription rates of ETI as compared to those with higher lung function of 90% or above. We found that those with at least one or more pulmonary exacerbation in the preceding year had higher ETI prescription rates compared to those without a pulmonary exacerbation in the prior year. And lastly, we found that those who had comorbid CF-related diabetes had higher prescription rates for ETI. What I show here is a race-stratified cumulative incidence curve looking at uptake of ETI by race. And just to orient you all, on the x-axis we have time, where time 0 is October 21st of 2019. So that was the day that the FDA approved ETI. And on the y-axis, I have the proportion of people with an ETI prescription. The blue line, I advanced too far. Let me go back. There we go. The blue line represents Black people with CF, and the red line is white people with CF, and the shaded areas are the 95% confidence intervals. What you can see is that early on during the pandemic, early on after FDA approval, there are similar adoption rates. But in the early phases of the COVID-19 pandemic, you see that those curves start to diverge before coming back again near the end of the study period. Here I show the the ethnicity stratified cumulative incidence curve, where blue represents Hispanic ethnicity and red represents non-Hispanic ethnicity. And you can see a similar trend here of Hispanic participants adopting ETI at a slightly slower rate, although not nearly as pronounced as with the race stratified curve. The last cumulative incidence curve I'm showing you is stratified by FEV1. So the green line represents those with the lowest lung function of less than 40% of predicted. Blue is between 40 and 70%, red is 70 to 90, and brown is above 90% of predicted. And what we're looking at here is really a monotonic relationship where participants with the lowest lung function are adopting ETI at the fastest rates. And from there, we see those with the best lung function are adopting ETI at the slowest rates. Lastly, we did a Cox proportional hazard model looking at independent characteristics associated with ETI prescription. And the outcome of interest here is time to ETI prescription. And so actually a hazard ratio above 1 here would be considered a good thing. So looking at age, we found that as compared to the referent group, younger people had higher hazard ratios of ETI prescription. Older people had lower hazard ratios below 1. We didn't see any difference by sex. And then when we looked at race, we found a lower hazard ratio of ETI prescription among Black people with CF. We also found a lower hazard ratio among people of Hispanic ethnicity. And as compared to private insurance, we found lower hazard ratios among anyone with Medicare, Medicaid, or other health insurance. When we looked at other clinical characteristics, we found that they were all significant. So looking at lung function, those with higher lung function of above 90% had lower hazard ratios of ETI prescription, whereas those with lower lung function had higher hazard ratios. Those with at least one pulmonary exacerbation had higher hazard ratios, as did those with CF-related diabetes. And we also found that those with prior non-ETI modulator use had higher hazard ratios as well. So I'd like to summarize for you all what we found in our analysis of the characteristics associated with ETI prescription. We found that those more likely to be prescribed ETI were those with lower lung function based on FEV1, those who had at least one pulmonary exacerbation in the prior year, the presence of comorbid CF-related diabetes, younger age, and prior non-ETI modulator use. Those who were less likely to be prescribed ETI included those with Black race, Hispanic ethnicity, having Medicare, Medicaid, or other insurance as compared to private insurance, higher FEV1, and older age. There were some limitations to our study, so we weren't able to determine what the reason was for not being prescribed ETI. There's also the possibility of confounding by visit frequency and access to care during the COVID-19 pandemic. And we only looked at those with at least one copy of F508del. So in conclusion, we found that people with CF with better health status were less likely to be prescribed ETI, which was not surprising to us and really fit with our hypothesis that people with better lung function would be less likely to be prescribed ETI. But what was much more concerning was that we detected a difference in time to first ETI prescription by race and ethnicity. It's also possible that the impact of the pandemic may have been differential by race and ethnicity. And one of our biggest takeaways from this study is that further research is needed to understand the reasons for this racial and ethnic disparity, and further work needs to be done to develop strategies to ensure equal uptake of novel therapeutics for all eligible people with CF. I'd like to thank the CF Foundation for the opportunity to use the patient registry, and everyone who contributes to the patient registry, including people with CF, their families, and of course, clinicians and care coordinators, and of course, my co-investigators on this study. And I would be happy to take any questions. I'd also like to point out my poster number is 401, so I'd be happy to talk to people at the poster session as well.
Hi, Megan McGarry from University of California, San Francisco. So, I mean, this is devastating. These are people who are DEL-508 not being prescribed. I mean, you can blame it on the pandemic. You can, e-prescribe. So I think we really need to all really have a sober look at this. And like, what are we doing, you guys? This is awful. These are the patients that are already doing worse. All the data on like the health disparities are pre-modulators, and yet we're not even prescribing the modulators. It's really bad. And we all need to take a look at our own centers and really think about why are we not prescribing? And we need to really think of these patients as high risk and should have been first on the list. The day that it was, we need to prep these people that it was coming and we need to prescribe. So, I mean, this is awful. I cringe for thinking about how like health disparities are going to be going on after this. Gosh, it's just bad. So, I mean, these groups already are less likely to qualify for modulators. And then the people who are the easiest with DEL-508, we're not even prescribing. So I really implore everybody, this is from our centers. This is not somebody else doing it. This is us to go back and like really care for these patients. So thanks for doing this work.
Yes, thank you, Dr. McGarry. I completely agree. Thank you.
Hi, Georgine.
Hi, Dr.
Thank you
Sun.
for the awesome talk. I'm Bob Sun. I'm a clinical fellow at Boston Children's. I had a question about the lung function measures. My understanding is that in this time frame, the percent predicted FEV1 that's reported to the registry would be based on race-based equations. I'm curious how you think that might impact your interpretation of your results currently, and whether you've considered pulling absolute FEV1 back from the registry and doing a race-neutral calculation through z-scores, given our new equations and what we just heard in the previous talk.
Yeah, thank you for that question. And as Rachel just pointed out in her excellent talk right before this, I think we do need to consider looking at race-neutral models instead. And you're right, this was the race-stratified FEV1. And so I think that would be a great place to then take this work and see if we do look at absolute values rather than the percent of predicted, does that change things? Are we potentially even missing the severity of lung dysfunction in some people by sort of overestimating their lung health? So I think that's an excellent point and definitely an opportunity for further work.
Thank you.
Good morning, Michael Schechter, Children's Hospital of Richmond. I'm one of the co-authors on this presentation. Thank you for doing a fantastic job in presenting it. I do want to make, I think, an important point here, somewhat in reference to the last presentation and especially in reference to this one, which is that there's a variety of reasons why patients don't get prescribed these medications. And I think that rather than just sort of saying, oh my gosh, there's a whole bunch of people at the, physicians and providers at the care centers that are, not doing what they should be doing. I don't disagree with that, but it's not necessarily at a racial issue, a racial level. So, number one, what's I think important is that I think we do have a gap in trust. We do have a gap in the relationship of patients to the care centers. And I think that straddles both race and ethnicity and also social class. And so, again, the issue about Medicaid also being a marker of lower uptake, I think is something that's important. And I think that, we don't yet have this data in the CF population, but there is data in the general pediatric population, at least, about the differences in interactions between healthcare providers and people who, again, are either lower social class or of non-white race and their experience of care. And so I think that we need to understand that there are those sorts of differences that, again, are unconscious and so on. But the result is that we have patients who, therefore, a little bit more skeptical about new therapies. And I think that that's part of the experience. And that's part of the reason why I can tell you in my own CF center, we have non-white patients who don't want to start the medication for whatever reason. And it's not for want of trying. It's because, again, there's just that sort of gap. The other thing I just want to mention, we did an analysis 20 years ago or so looking at, based on Medicaid status, the prescribing habits of different chronic medications, and didn't find any difference. And in fact, if anything, found that Medicaid patients tended to get more treatment. They tended to get more chronic therapies. They tended to get more hospitalizations for pulmonary exacerbations. Again, these are efforts made, I think, by providers who recognize potentially patients at risk. The difference going back then, and I think it's applicable here as well, is that we had a signal back then that the newest medications were not picked up quite as fast. And I think we've seen that with other modulators as well, with a study that Greg led a few years ago. And I think that one of the other things that's going on is that we have patients who are better at, and other patients who aren't as good at self-advocacy. And so, again, those of us who are healthcare providers know who is on the phone calling us the day that there is an announcement of the availability of ETIs, and who insisted on getting things as soon as possible, as opposed to ones who would come in and, oh yeah, okay, yeah, I heard something about that, tell me more. So I think that there's a lot of different issues that are going on that need to be sort of teased out a little bit in terms of really understanding this.
Absolutely. Thank you, Dr. Schechter.
Hi, Samia Nasser from University of Michigan. So I really think that's a great first step. So I think your next step would be really, and I would recommend that for you and the group, is to look at the non-white ethnicity that you identified, and maybe develop a questionnaire to ask the providers around the country, why wasn't the ETI prescribed? So it could be that their lung function was good. It could be the lack of trust, which I see quite a bit as well. And you really keep working on it. So it's not lack of, and I'm not defending, it's not lack of prescribing, but what the reasons for it. So I think that would be a very good point for me to see what is the differences.
Thank you. And I think not only asking the providers, but also the patients and their families too.
Right. And we have a lot of very vocal patients that can actually give you their opinion as well. So
thank you.
Thank you so much for this presentation. I'm Aaliyah Magare, Coordinating Center in Seattle. I just wanted to express my deep discomfort for any denial that racism is a factor here. That denies the experiences of patients, providers, lots of people in this room. So I'm sorry, Michael, but for a white man to sit up here and say that it's possibly not racism is inappropriate.
Hi, Susanna McCauley, Chicago. Totally agree, and would also say that trust is not the issue. Trustworthiness is the issue. People who are from minoritized communities have terrible experiences in the healthcare system. I can send you all many references on this, as well as, summaries of discussions. When you don't feel that the place where you're getting healthcare is trustworthy, when you don't feel that your concerns are attended to when you're in the emergency department or in the hospital, when you don't get care, you are not going to be as likely to take something new. You're not going to be as likely to self-advocate when you've tried to self-advocate, you get pushed down. So I completely agree with the prior comment, and I would like to advocate for community engagement around this. We know even in CFF Community Voice, there's an underrepresentation of people of color. And so we need to flip this switch and be trustworthy and ask people about their experiences. But it's a great study, and I'm glad you did it.
Yes, absolutely. Thank you to you and to the former commenter for your comments.
Hi, Sade from the University of Texas Southwestern Medical Center in Dallas. This was a great presentation, and the medical student who presented did a fantastic job as well. And I just wanted to say, I know that it's challenging for us to look back at ourselves and say that we have bias, but we all have bias. And it's really, really important that we acknowledge that bias. And I do think that there's something that we can do to mitigate that bias in more impactful ways, not only investigating what our bias is, but, really, really engaging with patients from the beginning, as Dr. McGarity said, and really educating from the very beginning, not blaming their education level, but blaming our education ability for those patients and advocating for those patients. So thank you.
Thank you, Sade.
In conjunction with some of these discussions, I do also want to point out that tomorrow morning, Chandra and Dr. McGarry are leading a session on bringing health equity into the clinic. The more people that come there, the better the discussion is going to be. And we'll be continuing to have these discussions around how do we take the data that we see and turn it into something that's actionable. I think this is, I think, Georgine, your presentation is, again, just like the first presentation, just like many presentations, have identified gaps. Mm-hmm. But there's so many things that we need to do beyond just saying that there's a problem. And I think we're all in this room together to take that journey together.
Absolutely.
Thank you.
Thank you.
Now we're going to have a presentation by Kellen Madden. She has worked with the University of Pennsylvania to conduct this thesis project, and so we'll hear about her project.
Hi, thank you so much to the speakers who already went before me, and I'm really excited to be able to present at this session where people are clearly so passionate about this issue. My research is called Facilitators and Barriers to Increasing Equity in Cystic Fibrosis Newborn Screening. I don't have any disclosures. For background, as most people probably know, CF newborn screening was implemented at a universal level in the United States by 2010, and it's typically a two-tier system with first IRT levels. If that's elevated, then the sample will go on to some form of CFTR DNA testing, and this can really vary state by state because it's the states who are actually doing the screening. Some states will just do a select few variants on their panel, while other states in certain scenarios will reflex to full gene sequencing. Because states can choose what panels they want to use, this can lead to inequities, especially because people with CF who have African, Hispanic, Asian, and Indigenous ancestry, who hereafter I'll refer to as BIPOC, Black, Indigenous people of color, are more likely to have rare variants that aren't included on these panels. And this can lead to a higher rate of false negative newborn screen and delayed diagnosis. As has already been mentioned, there are other health disparities in CF. Newborn screening is just one element in these disparities. We know between 2010 and 2018, 21% of newly diagnosed people with CF were BIPOC, but BIPOC people with CF compared to white people with CF are less likely to be eligible for clinical trials and modulators, have worse pulmonary outcomes, and higher mortality rates. The aim of this study was to just look at the disparities in newborn screening and to explore the process of creating, evaluating, and implementing state newborn screening algorithms for CF. and to identify motivations, barriers, and facilitators contributing to a state's ability to implement equitable algorithms. This was a semi-structured key informant interview study, so we found participants through contact information on relevant publications and newborn screening websites, and we also used snowball sampling. The interview guide was based on a literature review and informal conversations, and it was piloted with 2 genetic counselors, and the interviews were performed over Zoom, and participants could receive a gift card. The interviews were analyzed on in vivo with an inductive thematic approach. 2 transcripts were reviewed by 3 investigators to make an initial code book, and that code book was then applied to the remaining transcripts independently by 2 investigators. Discrepancies were resolved through discussion, and the codes were organized into a hierarchy of themes and sub-themes, and participant states were classified as having expanded panels, which had more than 39 variants, versus limited panels. 6 participants were interviewed, and participants 3 and 4 came from the same state newborn screening program, so they were interviewed together. And all participants held advanced degrees related to the fields of genetics or public health. As you can see here, 4 of the participants were scientists in their newborn screening lab. 1 participant was a CF clinician, as well as an advisor on a newborn screening committee. And the last participant was actually a national consultant who worked with newborn screening programs across the U.S. And years of experience in newborn screening range from 2 years to 27 years, and each participant described a different step in the process towards implementing equitable algorithms, with 1 participant actually talking about what it was like to add CF to the panel for the very first time. Some participants have been evaluating their expanded panel for a long time, and other participants had recently updated to an expanded panel or are still trying to update to an expanded panel. 5 themes were identified in the interviews, and this was motivations for increasing CF newborn screen equity, the process of implementing equitable algorithms, barriers to this implementation, facilitators of implementation, and drawbacks of expansive algorithms. There were 2 motivations that were identified for increasing algorithm equity, and the first of which was the general belief or general knowledge that the current algorithm is not equitable. Participant 2 said, "We recognize that the previous panel was not sufficient, especially given the ethnically diverse population in our state." And it's important to note that a lot of participants had this general knowledge, but it was difficult for them to get specific concrete data to support this knowledge, as I'll discuss later on in the presentation. The second motivation was advocacy from CF clinicians within the state. Participant 6 said, "Definitely the CF centers are pushing more. It's coming from the outside saying, we need to change what we're doing. They're actually feeling the anxiety of the missed cases. So these clinicians are the ones who are interacting with the families who have false negative newborn screen, and then going on to advocate within the state to try and make sure that doesn't happen for families in the future." The next theme was the process of implementing equitable algorithms. And of course, this is a large process. It's different state by state, but 2 sub-themes really came up in our interviews. The first of which was the need to compare the detection rates of a CF newborn screen algorithm to the ethnic makeup of a state. And this includes the algorithm that's currently being used in the state, as well as proposed future algorithms. Participant 6 sums this up really well by saying, who's being missed? Are they being missed because your IRT cutoff isn't working, or are they making it to DNA and you don't have a panel that's covering your population? The next important part of the process was collaboration between different types of professionals, and this includes clinicians within the state, again, who are doing a lot of advocating, Department of Health administrators, the actual staff of the laboratory, and the newborn screen follow-up team. Participant 4 said, "We have a good working relationship with our CF care centers, and we have regular meetings with them to work on this collaboration." The next theme was barriers to implementing equitable algorithms, and 4 barriers were identified. The first of which is probably not surprising, is funding and purchasing, and this could refer to overall funding for a newborn screen program, which participant 1 is talking about. You only have a certain amount of funding, so do I push for this, a new disorder, or do I push for doing this a little better? There's a lot of conflicting purposes, and if you don't have a lot of money, it's even harder. And it is important to note that a lot of times the overall funding for a newborn screening program has to be approved by the state's legislature. And the other element of funding is the purchasing of new equipment, and that ties in actually to the next barrier, which is the logistics of incorporating next-generation sequencing into a public health laboratory. Participants noted that CF is often the disorder that brings NGS into a public health lab for the first time because some of these panels are large and they require this technology. So state newborn screen labs have to be able to have both the funds and just other logistical ability to acquire the new equipment to do NGS. This also brings in a much longer protocol, which can alter the lab workflow that has probably been happening for several years. And it's really important to have genomic expertise and education. So someone in the lab has to be able to interpret the results of an NGS test. And the newborn screen follow-up team also has to be trained on how to explain the results of that test to the pediatrician or to families. Participant 4 said, NGS is not trivial to do for a newborn screening program. Not many have next-gen sequencing technology, and Sanger would be very difficult to do at this scale. The next barrier was staffing issues, and this could refer to just generally not having enough staff, which was especially an issue during the COVID-19 pandemic. This is what participant 2 was talking about. At times it was kind of like a roller coaster. Sometimes we would feel we're getting really close to going live with it, with their new panel, and then our staffing took a hit, and we're like, well, we can't sustain this right now. And then again, it's also important to have staff who do have genomic expertise, as well as staff who have the motivation to address inequities, who are more willing to look into possible problems rather than just staying with the status quo. And the last barrier was limited follow-up data. And the fact that it's really hard for some of the newborn screening programs to have follow-up data is why a lot of the participants just had this general understanding or belief that their panels were not sufficient for their population. So the follow-up data can refer to the outcomes of screen-positive cases. Did that infant go on to get diagnostic testing? Did they ultimately test positive? Are they just a carrier? Were they a false positive? And some of this can be because screen-positive cases might be lost to follow-up. Maybe the family never made it to the diagnostic testing appointment. And this can be because of other barriers that have already been mentioned today, like the distance to a CF center, or the fact that a pediatrician might not urge a family who is BIPOC to go get follow-up diagnostic testing because they believe that CF is really only prevalent in Caucasian populations. Also important is to receive identification of false negative cases. So if that's never reported to a lab, then they're not going to know that their screen is not catching all of the cases in the States. And then similarly to something that's also already been mentioned today, it's really difficult to get accurate ethnicity data. Most likely the ethnicity written on a newborn screen blood spot card is something that someone in the newborn nursery maybe looked at the parents or looked at the baby and guessed as to what their ethnicity was. That's not self-reported. The next theme was facilitators of implementing equitable algorithms, and there were 3 facilitators identified. The first of which was effective communication with CF clinical centers. And again, this goes back to getting that follow-up data. This allows the state programs to have information about their cases. And this is what participant 1 is saying. You have to have long-term follow-up. You need that collaboration with CF centers to report back when they have a false negative case. And this is also just generally important for collaboration to improve algorithms, to be able to brainstorm together about what isn't working, what can we do to improve this. The next facilitator was having enough staff with the proper expertise. So participants both, when asked about barriers, they said not enough staff with the proper expertise. And then on the other hand, some of the labs did have staff with the proper expertise, and this was brought up as a facilitator. And as participant 4 is saying, we have the staff with the expertise that's necessary to do NGS. If you already have staff with that education and expertise, it's that much easier to bring NGS into your lab. The next and last facilitator is the fact that there are extensive resources for CF compared to other genetic conditions. So especially people often compare funding for CF to funding for sickle cell, which predominantly affects Black Americans and people with African ancestry. But because CF does have a lot of funding and knowledge, and especially the CFTR2 database was brought up by many participants, this can make it a lot easier to receive grants to look into these inequities. But we know despite this fact that BIPOC people with CF are still facing all of these disparities. The last theme was drawbacks of expansive algorithms, and this is the detection of carrier status and clinically uncertain cases. And this is something that labs who have had expanded panels for a long time are really focusing in on now. As participant 3 says, because we're sequencing, we identify more babies who have an inconclusive diagnosis. So we hope that we will be able to reduce that number someday. This study did have limitations, so certainly a small sample size. There were 6 participants interviewed. However, it's important to note that CF newborn screening is a fairly small community. A lot of states use the same protocol for newborn screening or even use the same exact lab to do their screening. So the findings of this study might be more broadly applicable than would generally be thought for a small sample size. And there's also ascertainment bias. So we were using selective sampling to find participants who we know are working on these issues. So they are more likely to feel like there are improvements that need to be made. In conclusion, equitable CF newborn screening algorithms are one way to reduce health disparities experienced by BIPOC people with CF. Implementing equitable algorithms involves the evaluation of the current algorithm, collaboration between different professionals, overcoming financial and logistical barriers, and effective communication between clinicians and state labs. And then another finding of the study is that NGS has the drawback of increasing inclusive results, and we know that this is something that is happening across disorders on newborn screen that utilize genetic testing, and that's definitely a big conversation in the newborn screen community overall. For future directions to address the ascertainment bias, it would be important to interview representatives of states that haven't started looking at their algorithm and how equitable their algorithm is to identify additional barriers. It would also be really important to explore the experiences of families with CF who have received false negative newborn screens, because I think their voices are probably the most important in this conversation. And lastly, to investigate the impact of equitable screens on clinical outcomes. Thank you so much to the NSGC CF SIG for granting me a scholarship to complete the study, and to all of my thesis committee, my advisors, and co-investigators, and I can take any questions.
Hi, Katie Singh. I'm a genetic counselor at Miller Children's in California. One of the opportunities I see from this is communication. So every state has a different protocol. Every state is going to have a different negative predictive value on their newborn screen. And I don't think those are well communicated to the pediatricians who are receiving those reports and to the families. So in a state that's screening 1 or 2 variants, their negative predictive value is going to be so much lower. So how good it is at determining that this is really a negative result than in California, where we're sequencing. And almost all of my missed screens have had a high IRT. So I was struck by that comment, like, where's the difference? Is it the high IRT and then the DNA is missing it, or are you missing the IRT? And this is clearly a huge issue, but a fairly easy, low-cost intervention in the meantime is to have better communication about what a negative newborn screen actually means, so that out there in the community, the pediatricians might be thinking more about this kid who's coughing and, oh, well, they had a negative newborn screen, so this isn't CF. And that doesn't cost a lot to do that educational intervention, at least as a Band-Aid to try to get through these other inequities.
Yeah, thank you for that comment. I think most people who work in genetics know that it's a real issue that people who aren't as familiar with genetics don't understand the difference between a screen and a diagnostic test. So I agree. I think a lot of education has to go into that.
Hi, Susanna McCauley from Chicago. Thank you for this work. It's furthers and reinforces lots of themes that have been coming out in cystic fibrosis newborn screening. I wanted to make people aware that Marcy Sontag, who may not be in this room right now, is leading, are you here, Marcy? Hi, Marcy. Leading a collaborative learning between state newborn screening programs to kind of share some of this stuff and help position people for advocacy. And then we have also been working together through a Centers for Disease Control grant to try to make sure that there's better information, clearer information to primary care physicians. I think in the large number of states where they're the referral source, there are both misconceptions and misunderstandings. And we also know that sometimes the reports people get aren't very clear. So those are potential targets that I think everyone in this room, no matter what their role is, can help work on. So thanks for this work.
Thank you.
So you may not know the answer to this, but I think there probably are people in the room that may. One of the barriers you identified in the interviews was cost of implementing more expansive programs. Do you have just a sense of, what's the magnitude of this cost? Are we talking that it's, millions of dollars? Is it thousands of dollars? What's the scale here? Because I think it's very easy for administrators to often just say cost and staff. But I guess, do we have numbers to put to that so that when we go and talk with our newborn state programs that we have some information? And again, maybe you may not know the answer, but I don't know if there's anyone in the room that may.
I don't know the scale of the cost, but exactly like you said, it is often the administrators who are turning that down. But it's a really interesting point because I think newborn screening in general is going more towards these larger scale tests and next generation sequencing. And there's even a lot of studies right now doing whole genome sequencing on healthy infants. So that seems like the future for newborn screening right now.
Hi, I'm Mike Lewis from KU in Kansas City. For us specifically in the state of Kansas, we've been working at this for a very long time. It actually started our involvement when we found out that the software was so antiquated they would copy and paste things into the letter, and they actually messed up a letter. So that kid went from having one mutation to actually 2 mutations that was caught by an excellent genetic counselor. When the family went to have genetic counseling done to have another baby, they found the actual new information. That baby went from CRMS to CF, actually. So it was kind of an interesting story of that one kid. So our state has put a lot of effort into that. One of the software updates that they need to start to really be able to do floating IRT with at a good level, I would say, is going to cost them about $500,000. And we already outsourced the DNA out to Wisconsin. And so that, you asked for a number, I just tell you, $500,000 in Kansas right now.
Victor.
Hector Gutierrez from University of Alabama, Birmingham. We have been participating in the Alabama newborn screening since 2008. I think we have 4 misdiagnoses since then. We're fortunate that we are the only center who controls all the newborn screening, and we are the center who receive all the positive newborn screening. So you have in the future directions interviewing families who are missing the diagnosis. For me, a very simple measure of being equitable, who I'm missing. I might add extra burden, and we were adding extra burden to patients, babies who were African Americans, who were positive for newborn screening for mutations that do not convey disease. So the stress of families actually was in reverse. They were affected negatively by being identified as a potential patient and not being patients. So we work with the state to change our panel to eliminate those patients who are not there. But when we assess the missing diagnosis are not affected more the percent of Black population in Alabama, which is, by the way, is more than double that the national average is 27% in Alabama versus 13% in the U.S. So what I'm trying to say is the patients who are missed by the newborn screening are not being affected, and sometimes we overdo by selecting patients in the panel who are truthfully negative. Okay, thanks.
Yeah, thank you for that comment. And that is definitely the greatest battle with newborn screening or any screening test. You need to identify as many cases as you can without putting undue burden on people who are going to have false positive tests.
Hi, Aaron Chitticle from Delaware. I'm looking on my phone because in the small state of Delaware, we're trying to expand our panel to the cost of $928.50 per baby. So I think that's a pretty specific answer to your question. We've also made the argument that in decreased sweat tests and other burdens burdens that are inequitably distributed, the cost would probably be saved. So thank you.
Yeah, that's a lot of the ways that people advocate for increasing screening. If we can diagnose people earlier and reduce the need for more long-term care, just in general across rare disease, that's a great way to advocate for better screening or diagnostic testing.
Marcy Sontag, Center for Public Health Innovation. Thank you, Susanna, for this shout out. I loved your presentation. This was great. And you brought up so many important issues on both the facilitators and barriers. And one of the cost issues, I think, I don't have the exact numbers for you, Greg, but one of the cost issues that I think a way to address this is to collaborate with others. I love the Alabama talk that, hey, we sent this to Wisconsin already. People can send, states can send it. So setting up next-gen sequencing and doing all of the testing in-house is hard, and it's also complex to interpret. So thinking about where else could you send those results so you're not doing it all in-house and interpreting it. But lots of issues. And I also would say, just a shout out to really partner with your CF center, or between your CF centers and your newborn screening programs, that's a good relationship there is going to make a big difference. And the CF Foundation is doing a lot of work in that area. So thank you.
Thanks.
Thank you. So our next presenter is Dr. Jonathan Guo from the Imperial College of London. He'll be talking to us about modulator access on a more global scale.
Great. So hello, everyone. Thanks so much for having me. Just to say I have no relevant disclosures. Great. So highly effective modulator therapies have revolutionized treatment of CF. However, prices have been set by the manufacturer Vertex at hundreds of thousands of dollars per year. More specifically for Trikafta, the focus of this talk, the price is 3.5 times higher than average yearly earnings in the US and 94 times higher than those of Turkey, an upper middle income country. For comparison, the oldest known person with CF in Turkey is 43 years old. The high cost of modulators means that even after regulatory approval, they remain functionally unavailable to patients unless reimbursed by national bodies. Even still, prices are so high that modulators pose resource allocation dilemmas to even the most robust of health systems, leaving patients waiting years to receive treatment and remaining a challenge to this day. This barrier is even more significant in low and middle income countries or LMICs with fewer healthcare resources. Despite this, there exists relatively little research concerning global patient access to these treatments. Therefore, in 2020, we sought to define the extent of international gaps in diagnosis and treatment access by estimating the total number of people with CF, the number diagnosed, and the proportion receiving Trikafta. Our results indicated that at the end of 2020, 162,000 people had CF worldwide. Of these, 65% had a diagnosis and just 12% were receiving triple combination therapy, exclusively in the US and Western Europe. Given the extent of global disparities, 3 years later, we aim to reappraise gaps in access and evaluate how sustainable, equitable treatment for all with CF can be feasibly achieved. We did this using the same multifocal methodology as our 2020 analysis. To estimate the number of undiagnosed CF patients, we used registry data detailing estimated patient coverage, alongside a systematic literature search for epidemiological studies estimating national CF prevalence. Together, these were used to generate the total number of expected patients in each country. To estimate the diagnosed population, we used 3 main sources of data, the first being patient registries. In countries without registries, we conducted literature searches to find data from regional studies or case reports. And finally, we also conducted an international survey of CF experts and patient organizations. To estimate the number of people receiving Trikafta, sales revenues were extracted from Vertex's 2023 second quarter earnings report. We then determined the proportion of revenue from different geographical regions from the company's annual SEC filings. Following this, the lowest price available in each region for a 3-month treatment course was derived from public pricing databases and used to estimate the number of patients receiving triple therapy, assuming a further 30% discount from negotiations with payers. Our results show that internationally significant gaps in diagnosis and treatment access remain. Currently, 189,000 people may have CF worldwide. Of these, 112,000 or 59% have a diagnosis, and around 53,000 or 28% are receiving triple combination therapy. Clearly, there remains the potential for a high burden of undiagnosed CF worldwide, largely focused in low and middle income settings. And importantly, though there was an increase in the estimated number of people receiving Trikafta, a significant gap remains between this and the total diagnosed population. And it's this that I'd really like to focus on within the scope of this presentation. So this is what our results for the diagnosed CF population look like mapped out, with darker colours representing a higher number of patients. When you compare this with where Trikafta is reimbursed internationally, it's easy to see a stark difference. Current country-level reimbursement falls far short of global disease burden, with Trikafta reimbursed in just 35 countries around the world, compared with 96 where people with CF were identified. In practice, this means a child here in Phoenix would receive the life-changing benefits of Trikafta from 2 years old, whereas just 150 miles south of where we sit today, this is denied to 1,000 children in Mexico. Disparities in access are further displayed when you break the data down region by region. In the US, we can see most patients are receiving Trikafta. In Europe, Canada, and Oceania, we can see this gap is larger, likely due to many reimbursement deals in these regions being more recent. And finally, in the rest of the world, just 914 people are estimated to be receiving triple combination therapy via generics due to the unavailability of Trikafta in these regions. In other words, 4 years after regulatory approval, at least 20,000 people in 61 countries have no access to Trikafta. And this represents a significant underestimate. If we account for the estimated undiagnosed population in low and middle income countries, this increases to around 90,000 or over half of the total estimated CF population. So profound inequities remain in the availability of CFTR modulators around the world. We can get a better understanding of the nature of the problem when we take a closer look at where access has been prioritized. In 2020, Trikafta was available in just 6 countries, and since then, global reimbursement has increased. However, this is almost exclusively limited to the richest countries in the world, with Bulgaria the only low or middle income country where Trikafta is accessible. This strategy means it's unlikely significant further progress will be made in global access, as reimbursement deals now exist in almost all high-income countries with high CF populations. This stark inequity has sparked a global campaign composed of clinicians, patient organizations, advocacy groups, and legal experts from over 50 different countries, some of whom are here today, and I'd encourage you to have a chat with them. So the elephant in the room really here is that cost remains the primary barrier to equitable global treatment. And so I think it's worth asking why are prices so high? Some justifications center around high production costs for novel therapies. Yet our analysis estimating minimum costs for these medications indicate they are 98% lower than their retail prices. This is compounded by the availability of generic modulators produced in Argentina for a fraction of US prices. And furthermore, within their submission for Trikafta to the Australian Health Technology Assessment Board, Vertex themselves have internally estimated that loss of market exclusivity and subsequent entry of generic competitors would result in price reductions of 90%. Other rationales relate to the costs of research and development, and it's of course vital that these costs be recouped to fund further research and drive innovation. However, CFTR modulators represent some of the most valuable orphan drugs on the market, with total revenue since 2018 reaching $35 billion. By comparison, even if we assume that all R&D expenditure at Vertex from 2001, when they first acquired the work on modulators, until 2019 was only attributed to Trikafta, which is of course an unrealistic assumption, this cost of $12 billion would be recouped in just a year and a half of 2022 revenues. And finally, some would point to the health benefits conferred by modulator therapies in comparison to supportive care. Yet cost-effectiveness analyses by national and independent bodies have concluded the benefits of CFTR modulators, while profound, do not warrant their prices, recommending price reductions of between 75 and 90%. And so we can see prices are not determined via production expense, R&D cost, or efficacy, but rather what the market will bear. Overall, it is clear the status quo is failing, and as a result, thousands of patients in low and middle income countries around the world are being left behind. So what can be done? We can start by looking at a real-world example of how people with CF are overcoming this barrier. In South Africa, some patients have resorted to buying generic modulators out of pocket. While a fraction of originator prices, they still have been forced to switch to twice-weekly dosing with concurrent use of cytochrome P450 inhibitors to reduce hepatic metabolism and stretch their supply of medication. From outcome data published by their physicians, we know that with this regimen, we are already able to effectively reduce the cost of treatment by 95% from $325 to $15,000 per year, while achieving improvements akin to those seen in Trikafta's phase 3 trials. However, it should be noted this is preliminary observational data requiring further investigation in a more formal controlled setting before I think we can consider this as a sustainable or long-term solution. In view of this, one strategy which we've previously advocated for is voluntary licensing, wherein the originator company permits third parties to manufacture and sell specific products whilst they remain under patent, while charging a royalty fee for profits. This is a policy with a proven track record in other disease areas and resource-limited settings. In the case of antiretroviral therapies used to treat HIV specifically, it allowed similarly prohibitive drug prices to be reduced by over 90%. However, if we compare the policies in place for these therapeutics with those for modulators, we can see a clear distinction. With the only tangible action taken by Vertex a limited compassionate use program, restricted to countries where they expect to gain a reimbursement deal. And in fact, Vertex have repeatedly taken actions which actively work to limit access and protect exclusivity. For example, their recent decision to slash copay assistance to patients in the US. This on the background of high existing out-of-pocket health expenditures for people with CF, and the fact that before the approval of Trikafta, 2/3 of people were already experiencing debt, food insecurity, or housing issues. Vertex have also filed patents in countries where reimbursement deals are not currently being pursued, thereby effectively blocking alternative routes to access, and even taken legal action against generic producers looking to supply underserved countries. And so whilst voluntary licensing appears a promising solution, it relies on the cooperation and good faith of the manufacturer. Given Vertex's apparent lack of transparency and commitment to providing equitable treatment, it appears necessary to consider alternative routes. Compulsory licensing is a flexibility in intellectual property law, allowing governments to unilaterally override patents and permit generic manufacture of pharmaceutical products. It's enshrined in the 2001 Doha Declaration on Public Health as a means to aid governments in ensuring access to medicines for all. There's a strong precedent for their use with over 150 successful cases documented internationally in both high and low income settings. Such patent challenges are already underway in 4 countries around the world, those being Brazil, Ukraine, South Africa, and India. Past cases have shown that a compulsory license application does not need to be approved to be successful. Often the threat alone is enough to enact policy change. Indeed, since applications were submitted to Brazil and Ukraine, a new offer for a further discount was made to the Brazilian authority in June after years of little action, and agreements for some form of access have now been made in both countries. I think it's also worth taking a closer look at what some of these actions actually look like in real life. So in South Africa, the Competition Commission has launched a formal investigation into Vertex on the basis of alleged excessive pricing, refusal to supply scarce goods, and exclusionary conduct. In addition to this, a person with CF called Cherie Nell has begun a high court case alongside other stakeholders to override the patent on modulators. Already, we are recreating the mistakes of the past, with patients forced to sue for access to life-saving medication, experiment with their own health, and crowdfund so they can fly halfway around the world to Argentina to bring back generics in their suitcases. And though an uncomfortable truth, it would be remiss to not acknowledge that ultimately, the root cause of this suffering also results in the manufacturer enjoying record-breaking profits year on year. In data from the European CF registry presented in June, it was shown that huge disparities remain in modulator access between richer and poorer countries, even amongst those with reimbursement deals. And one can already see the effects of this inequity, even within Europe, through the market improvements seen in FEV1 in 2021 after modulators became available in high-income and middle-income countries, with those in low-income settings where poorer outcomes were already experienced pre-modulator left behind. If we do not take urgent action, existing disparities will only widen, and we risk creating a 2-tiered standard of care. In a recent paper published in JCF, researchers modeled long-term outcomes for people taking Trikafta versus other treatment options. The choice of scenarios within this model of early Trikafta initiation compared with basic supportive care alone as an adult can almost be seen as a direct modelling of potential future health disparities. It should also be noted this was modeled for a UK-based population where the baseline median age of survival is relatively high. Comparatively, in some centres in South Africa, this figure is as low as 20.5 years old. With phase 3 trials for a new triple combination modulator expected early next year, at this juncture I think we need to ask, what do we want the future of CF care to look like? At last year's conference, I was quite struck by this slide in particular from the second plenary session. It of course refers to the fact that around 10% of people with CF remain ineligible for modulator therapy. And rightly, it's a clear international priority to close this gap and deliver similar life-changing benefits to all patients. However, today, Years after the synthesis and approval of Trikafta, tens of thousands of people are also denied these benefits, not on the basis of clinical eligibility, but due to the country in which they live, representing a profound failure of public health. Therefore, we believe that disparities in access to modulators are a foremost issue facing the international CF community, and would urge stakeholders to adopt a similar commitment to making equitable access a top priority on the research and policy agenda. To put it very, very simply, the existence of life-changing treatments means nothing without the ability to access them. And to conclude, I think often with issues on this scale, it's easy for things to get depersonalized. The problem's so big they seem distant and hard to fully conceive. And so I'd like to hand over to my friend Erte, who is a CF parent from Lithuania, where there's no access to modulators, to share her lived experience of this issue.
Here I am, a mom of a 3-year-old daughter with CF from Lithuania, is standing in front of all of you. A desperate mom whose child is condemned to a slow and painful death without a life-changing CFTR modulators. If you wonder how am I doing, every day is a struggle. Despite all the joy our daughter brings into our lives, every day is a fear. Fear that she won't make to her 20s. Despite all of our effort to keep her safe, despite all the treatments and physiotherapy that we're doing. This is not enough. You know it very well how sneaky and dangerous this disease is. How many kids and adults have died in the agony of organ failure and not being able to breathe. Every day I watch Milda, I know that I live with a death behind her shoulder. And imagine how a parent should feel as other countries has an access to this miraculous drug. Kids can live normal life, explore, live fearlessly, and you have to be cautious and in fear all the time. If she has touched something and put in her mouth, will she get dangerous bacteria from being near a pond or swimming pool? How it's frustrating not being able to do normal activities. Constantly measuring her weight, height, calculating calories, and being in isolation as other family members don't have knowledge how to do her treatments. How to live, how to work, how to provide to your family, being a burden to your country? Is this a life? Or even considering to leave everything behind that you have created only because you have a child with this rare disease and you don't have an access to these modulators. Leave your family and friends? Please help us. Stand with us and be our voices.
So I'm happy to take any questions, I should say. Thanks.
Yeah, this is Samia Nasser from University of Michigan again. So thank you very much, Jonathan, for this amazing presentation. So I do work a lot with the Egyptian community. The median survival there is about 8 years old. So no access to modulators. And been working with Vertex for a long time. I don't know if that will ever happen. I hear a rumor that there is a patent they're trying to get, and if they get the patent in Egypt, they will prevent access from any other thing. And the compulsory licensing that you talked about will be really very hard to get. So it is a very hard situation. You go there, your heart is broken, talking to parents, talking to kids, seeing them dying in front of you. So I really think something needs to happen. So thank you.
Thank you.
Hi, I'm Judy Epstein from Cooperman Barnabas in New Jersey. I'm a social worker. I heard your presentation last year, and when I saw you get up, I was like, oh, yes, again. And
thank you.
I think that your presentation is one of the most important presentations that I have heard ever at, and I I just want to thank you and your team for the work that you've done and to open our eyes. I mean, we always know about disparities in our own country, but to hear about it in international countries. And, you know, I'm heartbroken for you and your family that you're not able to access this. And I think it behooves all of us to, you know, stand up and really have our voices heard. So thank you so much.
Thank you. That's very kind. And just to say, you know, I think the CF community is an outlier in that they pioneered, really willed these treatments into existence over the course of 20 years through close collaboration from stakeholders, clinicians, researchers, patient organizations, and everyone. And so if we pioneered that, why can't CF also pioneer increased access in these sort of rare drug communities? There's no reason. And so, yeah, thank you very much.
Hi, Janessa. I have a daughter with CF. She's 3. I just first want to say, can all of the ladies and men are involved too in the Right to Breathe group stand up so you can see all of them? Know their faces, look at their shirt. I'm gonna cry. These women, these men that are involved in this group are so amazing, so inspiring. I've talked with our team a long time now. We both have daughters that are 3 with CF, and the difference of care and the access to the drugs is just, it's not fair. I'm sorry. This is so important. So I want all of you to make sure you talk to them, be a part of what they're doing. It's very important. Thank you.
Hi, I'm Grace Paul from Nationwide Children's Columbus, and I was really looking forward to your talk, Jonathan, because you are excellent, and each slide has so much depth into it, and we can spend so many hours just like looking at the data. We work a lot in CF in India, and my collaborator Sneha is also here. From our preliminary data, we believe there could be at least minimum 100,000 patients in India, and based on our genetics, at least 60% would qualify for Trikafta. But I know all of them are going to die right now because there's a huge patent law that prevents any Trikafta being manufactured. As you guys know, India has a big generic medication manufacturing industry, but we are very limited now by the patent laws. It's also interesting that the CEO of Vertex is an Indian lady, which I cannot understand that. My thought on how we can improve this is just showing numbers and somehow showing that we can reduce price by just giving them the market. This is your huge 100,000, 200,000 market. Reduce the price, you will still get your profit. But so that's what we are working on, and that's what my encouragement to all leaders from CF centers in low and middle income countries is to do. So thank you so much, Jonathan.
Thank you.
Hi, Megan McGarry from University of California, San Francisco. So we just need to acknowledge that this is not normal. This is not normal behavior for a pharmaceutical company. This is not the way that it's been in the past. We don't have to break new barriers to get access internationally. HIV and AIDS medications did that. Vertex is not going to lose money by giving access to international communities. They will make more money. They are making record-breaking profits. They are not putting that money back into development. They just did $3 billion worth of stock buybacks to raise their own stock price. So they are serving stockholders. They're not serving the CF community who did the trials, who did the basic research. They are not. They are continuing to do research in international countries and not publish it. They have sequenced and done modulator testing in Brazil. Where is that paper? Why are they not publishing it? Why are we not seeing it presented? So they are using the CF community. They are not caring for the CF community. The drugs don't need to be this expensive. They can give access so we can have generic drugs, and they are refusing. This is a moral issue, and we have pleaded to them, and they don't care. They have acknowledged, I have heard in quotes, gosh, it's really bad what we're doing to Ireland right now, but I hope it'll get done soon. Like, and in the meeting, you can do something about it right now. They could change today they could change during this conference, but it will take pressure. They have said before they hope to divide us, to make this go away, and it cannot go away. We have to be thinking about our whole community. If we care about a cure for all, then we need to care about a cure for all. And if you only care about people in the United States, well, guess what? I have a name of people who can't afford their drugs now because now they've made further changes with the copay adjustment program that they can't get drugs. No one can afford to pay this. You know, we need to speak out. So you all have phones right now. Today, email. Just send off an email and just say what your role is in the CF community, that you really care about this, and that you want Vertex to take action now. And so please speak out. It really does matter. And I just thank you so much, the people at CF and the families at CF that keep speaking out. I mean, the burden is on you. I thank you so much. And I hope that we can help you. So.
Hello, hi. My name's Gail Pledger. I'm a CF mum from England. I am a founder of Vertex Save Us global campaign group and of the Right to Breathe campaign. I'm here today. My daughter's life was transformed by Trikafta 3 years ago. She went from regular hospital visits to none at all. And following a UK campaign that we had, because it took us 4 years there to get access to this drug, even in a high income country, we formed the global campaign. So I'm here today with Urte and Pratibha here. Stand up, Pratibha. Because my daughter is thriving while these two have daughters that are doomed without access to this drug. So please come and support us. We've got a website, righttobreathe.net. You can sign a petition. You can sign a clinician's letter that goes to Vertex, because we want to give them the clear message that our community, which is really strong, which is I'm so proud to be part of, will stand together for people like these. And we won't stop until everybody has access.
Hello. Hi. Good afternoon, everyone. Jonathan, I've been following your work for a while now, and then also Dr. McGarry's. I'm one of the research coordinators and also an international medical graduate from Columbia University. And I've been working on this question on here in the U.S., we have federal government covering from some of the costs of the individuals, patients with, people with cystic fibrosis. How is this in other countries in which, they have the patent, they're covering from the cost of the patent, but not necessarily covers everyone in it? And this also causes that patients here that need to get access to Medicare to be able to afford somewhat the drug. That's what we see here in the U.S. How do we see this in other countries in which there might be several programs similar to Medicare and Medicaid?
Yeah, so depending on the healthcare system, of course, generally a national body like a government will basically pay for the price of medication for the patients. So it's either free or heavily discounted at the point of use, depending on your system. Unfortunately, there's a huge lack of transparency in how this actually works. We don't know the pricing in each individual country, and I think that's by design, so that companies can essentially leverage other countries to get the best deal for the company and not for the patients. So, for example, that discount, so generally there'll be a discount per patient. That could be any number. It's unknown, and quite honestly, I think there's quite a lot of research which suggests that's not based on anything really. It's sort of a black box that's a number essentially pulled out of thin air. So I can't give you a much better answer, unfortunately. If there was more transparency, that would be lovely, but that's the reality of the situation.
Hector Gutierrez from the University of Alabama, Birmingham. I have the privilege in my team to work with international teams, especially in Latin America, and we are expanding that to other countries as well. What to do? I encourage everybody. The community in the CF is very intelligent and bright and resourceful. I encourage you to read the WTO compulsory licensing. Just a bit of history. When the anthrax scare happened in the U.S., Cipro was a branded product. That was the first time the U.S. government threatened Bayer to produce more or get the compulsory license granted. They relinquished. The governments can do, this is not a a CF foundation or CF community. This is a governmental issue. Happens earlier with the Moderna and Pfizer vaccines. Why they were not compulsory licensed? Because the rich countries are very afraid of the compulsory licensing, and they didn't even trigger that bullet to themselves, to the risk of millions of people. And that's why we have a delay in brand new technology that can be produced in other countries. So we need to change the culture in government when medications like the vaccines and now these Lyme-changing medications are available. But it's more than just us signing a petition. We need to move to the government. And the FDA actually has the power to relinquish that. Just get informed, it's there. Because I have been reading that when I work with international teams. Mm-hmm. Thank you.
Thank you.
Thank you.
Okay, we want to introduce our final speaker. We have Anne Georgiopoulos. Okay, I got it right. All right, from Mass General in Boston.
Well, I'd like to thank you for inviting me here today to have the opportunity to present this data in this context and highlight gender and sex disparities among people with CF, and to follow these compelling and moving presentations. And so these are my disclosures. Historically, it's been well established now that females with CF experience worse health outcomes than males, including decreased survival and earlier need for transplant, more frequent pulmonary exacerbations, and a higher prevalence and earlier acquisition of Pseudomonas, with these differences manifesting particularly after puberty. So why might that be? This needs more study, but for example, we know that inflammatory markers such as neutrophil-free elastase in sputum are elevated at the time of ovulation. And this is the time that estrogen is at its peak. And the corollary of that is when women then start hormonal contraception, this suppresses the estrogen peak, and that's associated with improvements in these pro-inflammatory cytokines among women with CF. Emerging data now suggests that some markers of health, for example, rates of pulmonary exacerbation, may not improve as much when starting ETI, elexacaftor, tezacaftor, ivacaftor, for females as for males, and further work in this area is necessary. But even less work has been done to date to explore gender differences in the mental health of people with CF in either the pre or post-modulator eras. Gender differences in mental health conditions have been well studied in the general population. For example, anxiety and depression are more common in females, and attention deficit hyperactivity disorder, or ADHD, is more often diagnosed in males. So how does this compare to what we do know in CF? Well, in the International TIDE study of more than 4,000 people with CF ages 12 and above, the female to male ratios look comparable to the general population for anxiety. Whereas for depression, among adults participating in TIDES, males were unexpectedly likely to report depressive symptoms at rates equal to females. A study of ADHD among people with CF in Israel and Spain also had unexpected findings. In adults with CF, but not children, females caught up with males and experienced equal rates of attentional symptoms. Notably, all of this data was collected before the widespread use of ETI. So we wanted to bring this into the modulator era and use data from the Wellness in the Modulator Era survey to see if there were gender differences in perceived mental well-being and quality of life among people with CF after starting ETI. WellMe was a national survey sponsored by the CF Foundation. It was distributed in the summer of 2022 with a target audience of people with CF and parents or caregivers of children with CF. and we received a total of 900 valid responses. And the parents or caregivers of children with CF are reporting on behalf of their children, not about themselves. So WellMe was co-designed by CF Foundation staff, members of the CF community, CF clinicians, and researchers. The survey focused on 5 domains of well-being. Within these domains, we measured perceived changes in well-being since starting a modulator using a 5-point global improvement scale, ranging from much better to much worse. We included the adult and parent proxy versions of the PROMIS health-related quality of life measures. In addition, there was space for free text responses. Before I discuss our analyses by gender, I'd like to highlight some of the overall results that Erica Van Sitters presented at last year's NACFC. We asked, have you or your child experienced changes in the following areas since starting a modulator? Here you see the responses for people who were taking ETI at the time of the survey, so that was a total of 571 people. In blue, you see the percentage who reported experiencing improvement. In gray, those with no change. And in pink or red, those who reported worsening in various domains. So we see here that in most domains of well-being, people with CF report improvements far more often than they report worsening. When it comes to mental health, however, the picture is somewhat different, with worsening more common than improvement. We'll touch upon these specific aspects of mental health further in a moment as they relate specifically to gender. We took a closer look at this data, excluding children under 5 years of age and making 2 sets of comparisons, adult women versus men, and in the pediatric population, girls versus boys. And I do want to point out here that the number of people with CF self-identifying with a gender other than male or female was too small to be included in the statistical analyses here. But I am so pleased that there are projects in development that are being designed specifically to look at and focus on people with CF who are also part of the LGBTQIA+ community. So, and note here that although the number of respondents is relatively large, children represent only a quarter of the sample, which you will see also will have some implications for statistical significance in the pediatric group. This sample was 95% white and 61% female. So first we looked at mental health-related quality of life on the PROMIS measures and saw no significant differences by gender. However, when we look at changes since starting a modulator, we do start to see differences. Women were significantly more likely than men to experience worsening in overall mental health. The bars indicate the percent who perceived feeling somewhat or much worse, with women shown in brown, men in dark blue, girls in yellow, and boys in light blue. Asterisk marks significant differences between the comparison groups, in other words, women versus men or girls versus boys. As I noted a minute ago, this is an example where the pattern is similar for children as it is for adults, but the sample size was not large enough to reach full significance. I noted earlier that both in the general population and among people with CF, females are more likely to experience anxiety than males. So it's not surprising here that women were more vulnerable to worsening anxiety after starting ETI than men, and similarly for girls versus boys. When it comes to depression, women and girls, women and girls were more likely to report worsening than men and boys, and this follows the general population patterns. But remember, in TIDES, adult males and females had a similar cross-sectional prevalence of depression. So this is not exactly an apples-to-apples comparison, since TIDES reflects symptom prevalence, whereas WellMe data elicited perceived change after starting a modulator, but it's still interesting to consider. I didn't include them on this slide, but feelings of stress and guilt showed similar gender difference patterns in WellMe to anxiety and depression, which makes sense since they contract with these conditions. I wanted to show some of the qualitative data for a few of the aspects of mental health that WellMe explored. Here you see examples from people reporting improvement since starting a modulator, and examples from people reporting worsening for both depression and anxiety. These particular quotes demonstrate some of the CF-specific links between physical and mental health, such as anxiety related to hemoptysis, and also highlight the psychological and existential distress that can result from a potentially life-changing therapy. So anxiety and uncertainty about how I'm going to cope with and use the extra time that I have unexpectedly been given. Now I'm going to show a few more aspects of mental health where women were more likely to report worsening than men after starting ETI. The first is agitation or irritability, and this makes sense given what we just saw for anxiety and depression, since irritability can in some cases be a symptom of anxiety or mood dysregulation. We also asked about thinking clearly, including trouble with memory, focus, or word finding. Although women were more likely to report worsening cognitive difficulties than men, there were no differences between girls and boys. Although thinking clearly likely represents a somewhat different construct than ADHD, remember what I said earlier, that in the general population, men are more likely to be diagnosed with ADHD, although that doesn't seem to hold true among adults with CF. And we see a similar pattern with sleep disturbance. Again, I'd like to highlight comments from people with CF about a couple of these aspects of mental health. One person said, I have no patience for anyone, I just blow up. I never know what's going to set me off. I blame this for breakup of relationships. Patients should be made aware of this. It should be discussed in clinic before you start. There should be a warning on the box. And in regard to thinking clearly, very bad memory problems, have to write everything down. This has been very serious for me as a professor and researcher. Now, these sound less like psychological reactions than the examples I showed before, which raises the possibility that some of these responses reflect side effects of the modulator. Of note, the European Medicines Agency recommended a change to the Kaftrio label this summer. For those who don't know, that's the name ETI is marketed under in Europe. And they concluded that there is at least a reasonable possibility of a causal relationship between ETI and depression. When people are experiencing changes in mental health, this could include suicidal thoughts or behaviors or acting out. While we see no difference in adults, girls were more vulnerable to having suicidality emerge after starting ETI than were boys. And we see similar patterns for acting out. In the general population, we would not expect to see differences in oppositional or acting out behaviors in girls versus boys. Another aspect of mental health that is potentially impacted by starting ETI is body image and unhealthy eating behaviors, including binging, restricting or limiting food intake, overexercising, and enzyme or insulin misuse, which can be some CF-specific disordered eating. In the general population, women are more likely to report difficulties in these areas, and we see that here as well. The pattern is similar in girls versus boys, but not statistically significant. Here are examples of open-ended responses related to body image. One positive, with a person with CF reporting that they appreciate not being looked at for coughing all the time or looking sick anymore, and another reporting a worsening of body image related to weight gain after starting ETI. In the general population, men are more likely than women to misuse substances, and so it was not surprising to see that men were more likely to report worsening in substance use than women in the period after starting ETI. For most people, starting ETI corresponded with the COVID pandemic in the United States, and we know rates of alcohol use, for example, increased quite a bit in the general population during COVID. Finally, overall, people responding to the Well-Me survey tended to report an increase rather than a decrease in their sense of optimism. And as shown here, there was not significant gender difference in those who became less optimistic after starting ETI. In conclusion, after starting ETI, women with CF more often reported worsening in mental well-being than did men. These Well-Me data align with general population data showing women and girls at higher risk for depression, anxiety, body dissatisfaction, and disordered eating than men and boys, but substance use disorders being more common in men. However, Well-Me data showing acting out in girls worsening more often than in boys, and worsening cognitive difficulty in women more than in men is unexpected. There's more work to do to determine to what extent ETI may have a differential impact on mental well-being, and through what mechanisms. These could include an impact of sex hormones on modulator function, or sex hormone independent factors such as societal influences on people with CF who identify as women. We hope that this line of work will ultimately help us figure out how to reduce these risks. The WellMe study is just a starting point, and a key goal of WellMe is to stimulate further study, including this kind of work at the intersection of two TDN-supported research working groups, sharing the Sexual Health, Reproduction, and Gender Research Working Group, and PRIME, Prioritizing Research in Mental Health. I hope you'll stop by our WellMe posters and that you can stay for Plenary 3 on Saturday, which highlights mental health. There are a number of additional analyses and manuscripts planned related to the WellMe survey, including basic health needs, physical well-being and experience of care, and possibly transplant, body image, so stay tuned. And finally, I'd like to thank the WellMe study team, with special acknowledgement and thanks to Joel King for helping with the data analysis I presented today. And to Erica Van Sitters and Liz Yu, the leads of this study. Thanks are also due to the CF Foundation and to Community Voice for facilitating this study. And most of all, to the people with CF and parents of children with CF who participated.
We have a few minutes for questions.
Hi, I would like to ask you if there is any data on comparing not just ETI, but all of the other modulators that are in the market regarding the mental health status of the patients. We see that some of the patients prefer to withdraw from Trikafta or Kaftrio and change into another modulator because they perceive that their mental health are better kept while they change on modulator. In clinical trials before, we did not see surveys like the CFQR or we did not see the surveys of for anxiety and depression, the GAT7, the PHQ-9. They used to use more the EQ-5D in these trials. So I want to know if is there any data on comparing the usage of different modulators and mental health on the patients?
So the WellBe study did include people who were taking any modulator and people who were not taking modulators. And so for this analysis, we focused on people taking ETI specifically. When so we didn't look at the other modulators in relation to gender, but we did look at those graphs I showed of mental health more generally and the 5 domains of well-being for people on any modulator and then for people on ETI. And the patterns look similar. So we could, we could take out the folks who are on different modulators and maybe do a comparison with ETI, but my suspicion would be we might not find any differences there.
Hello, thank you so much for the presentation. My name is Christina Limke, and I'm a psychologist in a CF mental health center. And this topic has come up a lot when parents are trying to decide about Trikafta. And also, as a parent, I can understand how concerning it is to, dramatically improve your child's quality of life from a health standpoint, but then have them get to the point where maybe they're thinking about suicide. Those seem like so counterintuitive. I noticed as you're a psychiatrist.
Correct.
And so the question that I'm, trying to answer for families is how can we benefit from the Trikafta and also manage these side effects of mental health? Is there going to be any research or has there been on, how can psychiatric medications help mitigate some of this?
The only paper I know of that looks specifically at psychiatric medication trials as opposed to some of the studies that maybe separate out people who had been taking a psychiatric medication is a retrospective study at our center. Evelyn Baroud and Nivi Chaudhary and I looked back at people who I had seen as the consulting CF psychiatrist. We limited to adults for this review. And looked at people who, anyone who was taking ETI and had seen me at least once. And then we were able to categorize people into different groups, some whose mental health improved, some who essentially remained unchanged, some who clearly worsened, but it was not out of the realm of possibility of their previous course. And so we said this looks maybe possibly related. And then a group of 16 folks, or about 11% of our overall population of people with CF who had started ETI, who we thought there was a pretty clear probable relationship. And we looked back to see what were the most effective strategies for mitigating those side effects. And in some cases, they were psychotropic medications. So, for example, for brain fog or attentional difficulties, stimulant trials tended to be effective. Benzodiazepines tended to be effective for sleep, anxiety, and so on. And for most people, the most effective strategy was dose reduction. And there are lots of reasons that could be, including pharmacokinetic differences that people may have, that soon we may have some ways to start to look at that and individualize treatment so that people may be able to tolerate the medicine better. There are a couple of great studies out of the UK that showed that specifically used a dose reduction strategy and looked at sweat chlorides, and that they were able to keep people's sweat chloride within an improved range despite the dose reduction. So yes, there's a lot of interest in this area, and this will be really the first purview of PRIME, the Prioritizing Research and Mental Health Group, will be to try to look at this question in more detail.
Great, thank you.
Thank you. Well, we want to thank everyone for coming today. We hope that the information shared today allows us to all see that we all have a role in what we can do to assure that when we say a cure for all means a cure for all, we all play a part in this chapter in our patients' and families' life. We think about it, their book of life. We're helping to write that chapter. We play a role. So it's up to us to decide, how do we create a happy ending, and not just a happy ending for some, but a happy ending for all. So thank you guys. And we hope we see you at our session on tomorrow.